Hello, everyone, and thank you for being here with us today. Welcome to the McLean County Virtual Community Behavioral Health Forum. That's a mouthful. We are happy to have you with us this afternoon. My name is Kevin McCall, and I'm a behavioral health specialist with the McLean County government. I will be standing in today for our Behavioral Health Coordinating Council Supervisor, Tricia Malott, who sadly could not be with us today. To start, I'd like to talk for a second just about the forum itself. The McLean County Community Behavioral Health Forum is typically a one-day event consisting of multiple breakout sessions. But with the ongoing global pandemic, we have adapted our in-person format and are pleased to offer a wide variety of individual sessions related to behavioral health that will be offered through April of 2021. Please check out our website for a full listing of these sessions, which include topics such as COVID-19, youth mental health, coping strategies, and much, much more. All registration is free, and you can even register the same day. Sessions are held at varying times to allow for maximum participation by community members, but all presentations are uploaded to the McLean County Behavioral Health YouTube page, where some of you may even be watching right now. I will provide links for both our website and our YouTube page in the chat located on the sidebar. I would encourage you to check back regularly as we do make a lot of new additions there as we continue to add speakers for topics outlined by our planning committee. We hope you'll continue to join us throughout the next several months as we continue to offer these presentations. Even with the new look this year, the idea of a free community education and sharing of ideas originated out of the Mental Health Action Plan, which is adopted by the 2015 McLean County Board. This plan originated out of more than 100 community members that identified needs and best practices related to behavioral health specific to McLean County. In these uncertain and difficult times, we believe that it is more important than ever to provide education, resources, encouragement, or even simply recognition of life's challenges. During today's presentation, there will be a time at the end for questions. We ask that if you choose to ask a question during the presentation, that you provide enough context so that the question can be appropriately answered at the end. Without further ado, I would like to introduce today's speaker, Luke Raymond. Luke Raymond is a director of behavioral health at OSF Healthcare. In this role, he has focused on the development of a new behavioral health navigation program designed to improve access to behavioral health resources, fostering innovative resources such as online digital behavioral health, creating an EConsult for psychiatry platform, developing a system-wide behavioral health analytics platform, and cultivating community collaborations through the region served by OSF Healthcare. Luke is a licensed professional counselor and has worked at OSF for the past 14 years. He is certified in primary care, integrated behavioral health, and trauma-focused cognitive behavioral therapy. His clinical interests include ADHD, trauma recovery, and the management of anxiety. All right, Michael, you're up.
All right, good afternoon, everybody. Like Gentleman said, my name is Luke Raymond. I'm Director of Behavioral Health for the OSF Healthcare System. And I'm happy this afternoon to be able to talk to you all about some apps and tech for mental health. So what I'm going to do is hide my camera so you guys can focus on the screen, and we'll go ahead and get started. Okay. So first and foremost, sort of what we have to make sure that we always do with every presentation that we ever give is the major disclosures here, right? That I have no relevant material, financial, or fiduciary interest in any of these solutions or products that I'm discussing today, other than the professional implementation of a variety of these digital behavioral health interventions that we've worked on at OSF. The other thing I wanted to make sure that we talked about as part of the disclosure here is that some of the solutions I'm going to discuss as just sort of examples of what's available are really just a small sample. I'm not necessarily endorsing the implementation or the use of these particular solutions or companies. They're just an example of what types of interventions are currently available. And as we get into it, you'll see there's a ton of them available in the current landscape. Our agenda today is going to be an overview of what kind of digital and virtual health options exist. I'll talk some about our experience as a healthcare system, with virtual behavioral health. For those of you who aren't necessarily familiar with OSF as a system, we have 14 hospitals, soon to be 15, encompassing over 2.2 million covered lives. In addition to those facilities, we have about 200 outpatient ambulatory clinics. Within the behavioral health space, we have 2 hospitals that offer inpatient psychiatric treatment, as well as several hospital outpatient departments and ambulatory psychiatry and psychological practices. We also offer integrated behavioral health directly into primary care, as well as some digital and virtual health options that we'll talk about today. We're also going to talk some about what's coming next with regard to behavioral health and technology. First and foremost, though, I think we got to get the elephant out of the room. Mental health can only be described as having been a crisis for at least the last few years, if not the last couple of decades. We've seen increased demand for behavioral health services everywhere across the lifespan, but primarily what we've seen is a drastic increase in younger individuals who are interested in obtaining behavioral health services. One of the things that we focused on as a system, and when I say system in this context, I mean the larger healthcare system, is trying to reduce the stigma associated with receiving mental health. I work closely with a gentleman who's the president of the Illinois Psychiatric Society, and he's fond of saying things like, we told these folks to ask questions. Hold on, I might have screwed something up here. Give me just a quick sec.
We can still see your PowerPoint and everything. You're okay. You can just pause your camera if you want to shut that off, or you can leave it on.
Okay, thanks. Yeah, you can still see the PowerPoint. Good. Okay. All right, good. So my friend who's the president of the Illinois Psychiatric Society talks about how we've often worked to reduce that stigma, and now younger folks are absolutely raising their hand and saying, you know what? Yeah, we need this help. We don't feel ashamed. And unfortunately, what we don't have is the infrastructure in our mental health system to meet that demand. Now that's created a demand for virtual and digital health initiatives because of the provider shortage and the lack of available resources that are present in a lot of our communities. The mental health challenge has gotten so large over the last few years. We actually saw a decrease in life expectancy between 2017 and 2018. And the CDC reported that this was really the first time we've seen that since the last pandemic, the Spanish flu epidemic in 1919, 1920. They isolated 2 variables that caused this. First was opiate overdose deaths. This is not the purpose of today's discussion to talk about the opiate crisis, but it's still there, and COVID has had a major impact on it, making it worse, and also suicide. So these so-called deaths of despair are preventable, but if we're going to make an impact, we have to be creative. We have to engage with people where they are and work very hard to continue to reduce that stigma and improve access to these behavioral health interventions. So all of that being said, before COVID hit, we were already in crisis mode in mental health and behavioral health. We were really just trying to keep up and tread water and keep our heads above water. The impact COVID has had on mental health really cannot be overstated. I screenshotted this from the CDC, and it talks about this 40% of adults struggling with mental health or substance use during June of last year. 40%. So this is 2 out of every 5 adults in the United States are struggling with either or a mental health challenge or a substance use problem. This is incredible, and it's worth even a deeper dive. So that little bullet below there, that seriously considered suicide, for those of us who are involved in mental health, knowing and realizing that 11% of adults reported seriously considering suicide during this period of isolation in the pandemic is flabbergasting. It's very scary. And this has been reflected in a lot of our volumes across all of our areas of business for behavioral health. One of the things I do in my job is that I'm a data nerd. Okay, so I focus on the analytics. I dig deep. I look at these numbers. We saw significant decreases in volumes in all of our emergency departments and all of those 14 hospitals during COVID. People were staying home even if they had a heart attack or a stroke because they were sheltering in place and trying to do the right thing. But that wasn't true for mental health. Our mental health visits to our emergency department actually increased in 2020 rather than decreased the way that all of our other all-cause visits did. This was particularly noticeable and prevalent among younger people. The most recent data nationwide that the CDC has published shows that there's a 24% increase in mental health visits in 2020 for kids aged 11 to 15. And kids who are 12 to 17 saw a 34% increase in mental health visits in the emergency department. So what we already had was this powder keg for mental health, and then COVID lit the fuse and blew it up, to be honest. So what that's done is this has created an even more sort of pressing need to engage folks with virtual and digital options. So as we move forward, what I want to do is really just start out with some operational definitions here. We hear a lot of different definitions floating around for sort of how to articulate the difference between digital and virtual health. And, we hear about video visits and this and that. It becomes kind of confusing and we get lost kind of in the weeds. So for the purposes of today, we're going to define virtual health as a synchronous, real-time interaction for the purposes of a traditional health visit. So for virtual health, think about those video visits that have become super popular with providers and patients. That direct back and forth communication like we do on Zoom or on a FaceTime call with family members, et cetera. Digital health, we're going to define as a patient-driven health initiative that's done digitally with the use of technology that may or may not include asynchronous interaction with a healthcare worker. So this can be broken down into even further in a variety of ways. And some solutions that we're going to discuss today and that are commercially available offer some degree of both types of intervention. So this virtual sort of face-to-face interaction with a healthcare provider informed by digital kind of data or digital phenotyping that it's called to connect the dots and give that patient a more rich experience and give the provider a greater depth of information to be able to meet that patient's needs. So moving into some of these sort of digital mental health approaches. Without getting too far into the weeds of definition, it is, I think, important to sort of separate out digital mental health interventions into these two sort of buckets, right? So we have digital therapeutics, typically refer to these digitally delivered cognitive behavioral therapy kind of exercises. So these can be for things like depression or anxiety or CBT for sleep. And they are often augmented with a coach or a supporter, and sometimes they're completely standalone. You get the CBT content, you work through it on your own. It's completely anonymous and confidential. These are most commonly used for those conditions that do respond well to a very structured form of therapy, including things like depression and anxiety. There is a ton of research now, empirical evidence that have validated the efficacy of such approaches, including here in the US and across Europe and other countries. Now compare that to these wellness apps, which tend to focus more on health and well-being. There may be some similar components to cognitive behavioral therapy, but they're at lower intensity level with fewer types of interventions. Using these apps and solutions can be very effective. It really can, and include activities that we're familiar with, like guided relaxation, meditation, yoga, stretching, and mindfulness activities. And as you can see on the screen, if LeBron endorses it, it must work, right? It's important to note here with these different digital therapeutics and wellness apps that there is sometimes overlap. And some of them do both CBT and those lower level activities. So it can become a bit confusing when determining which type of solution is most appropriate for your organization's particular situation. Now, as I mentioned at the onset of the discussion, that it's definitely a crowded space for apps for mental health right now. A basic search on that app store, whether you use iOS or Android, if you search for a mental health app, is gonna result in thousands of hits. You're gonna have all different kinds of options for things that you want to look at, and they're all sort of cutely designed and well packaged and have all of these, really nice, slick commercial appeal. But the question often becomes, how do we know that they're effective? How do we know what they're going to cost? Is there unlockable content that comes at a cost later on? What's the business model of these apps? Is this a business to business, or is it directly business to consumer? Is there any of this clinical evidence for this particular app that we know that it works? And these questions are all really important as we look for different types of apps that could be effective. Thankfully, the good folks at the American Psychological Association have helped us come up with an app evaluation model that breaks these down into five very discrete steps. That first step is access and background. You can ask questions about, does the app identify ownership? Does it identify the funding sources and what the cost is and any conflict of interest you might have? Does it come from a trusted source? Is it easy to access? Does it claim to be a medical device or provide medical treatment? Are there additional or hidden costs? Do you have to be online to use it? Because internet access can be a challenge for some folks. What operating systems does this work on? Does it travel between operating systems? Can you access it from a browser, a tablet, and a handheld device? When's the last time the app was updated? So you can dig deep into that access and background kind of thing and sort of figure out what those criteria are and determine if it's something that you're comfortable using. Now, the second step, privacy and security, is absolutely huge when it comes to any kind of digital involvement, particularly those that are connected over the internet. And of course, security and the use of data and what the purposes are of that data that the app or the solution will collect. Do you as a user, or do users from your organization become de-identified in some way, or do they remain anonymous? Is it possible for a user to opt out of data collection? And is it possible to completely delete your data that has been collected as you move along? Are there any third parties that data is being used? That I would really strongly encourage anyone who is considering the use of a digital intervention for behavioral health purposes to focus heavily on this privacy and security kind of question to make sure that all of those concerns are answered in a very satisfactory way before moving forward with the use of such a platform. The third step is that clinical foundation. Now, most of us in mental health and behavioral health recognize the efficacy of things like cognitive behavioral therapy and mindfulness and positive psychology. These have a ton of validated clinical efficacy. We know that these things work. The question is, to what extent does the app translate that clinical efficacy into a meaningful use for the individual user? So we know that that works, but does that particular application on that app work? Are there empirical studies that have been clinically validated and peer reviewed that show the efficacy and the clinical foundation of that particular solution. Fourth step is usability. How hard is it to use? That's something you got to really pay attention to, understanding that if something's confusing or difficult to access or has to go through many different steps for folks to be able to access it, it's going to limit the utility and the usability. And then, of course, step 5, that integration toward a therapeutic goal. So to what extent does what I'm entering into the app contribute to me getting better? So moving forward into just discussing some types of different solutions that are available, remembering these 2 different buckets that we talk about, we're going to break it into virtual health and digital health. Virtual health, there are a ton available. Now, there's BetterHelp that has become sort of ubiquitous lately. Talkspace is one that's been around for a long time. There are certainly advantages to these types of platforms. The 2 primary advantages are access, so you can access it from home, easy to get on your phone or your laptop and sign in and talk to somebody. The other major advantage of these virtual health type of apps is that you have a much larger pool of therapists and providers to search from. If you live in a rural area or you live in an area where there's a pretty significant shortage of mental health providers, being able to log into a web-based platform and find a provider who fits your need, whether you're someone who is an athlete or if you have a history of trauma and you want to find somebody who is, really tuned in to your specific need, that's one of these major advantages. Now, the disadvantages are cost. Insurance doesn't necessarily cover these types of things. The business model for them often is a fee-for-service where you're paying cash for each session, or you're paying a sort of concierge model where you pay a monthly fee to get access to a certain number of sessions, whether that's directly synchronous video conferencing or texting back and forth, or some combination of those. Moving over to the digital health bucket, 2 major players in this field in the country now are MyStrength and SilverCloud. MyStrength and SilverCloud are very similar applications that focus primarily on the digital delivery of cognitive behavioral therapy content. Primarily, these focus on those, like I mentioned earlier, those kind of conditions that respond well to CBT, depression, anxiety, stress, etc. But as they move forward, they're adding additional content to make them more applicable to a variety of different users. Now, the advantage to these kind of platforms is that they're secure. They tend to have more anonymity. They offer a low threshold entry into accessing sort of treatment and understanding where you are through the use of validated scales, clinical scales. It offers people the opportunity to enter into mental health without having to make a difficult call or without having to talk to their primary care provider to get help. Those can be powerful tools to get folks help who otherwise might not. Now, there's some disadvantages too. Okay, so there isn't an immediate feedback loop. So if someone's using MyStrength or SilverCloud and they identify some high risk kind of concerns, there may not be an immediate response to those needs. The coach or supporter, if available, may not get to that day. So it might take a little while to get to those questions or red flags if they emerge. There are definitely some platforms now and solutions that have become available for helping individuals who have challenges with substance use disorder. I've listed a few here, and they can kind of be broken down into the same kind of buckets. There's virtual health, where it's that synchronous interaction between a provider and a patient. And those might include things like medication-assisted treatment, where a provider will start medication to help folks with withdrawal symptoms associated typically with opiate challenges or addiction. During COVID, we've seen that 12-step programs have kind of gone virtual, where there's a Zoom AA meeting or a Zoom NA meeting that can be helpful. There's also in the digital or virtual or combination realm, some peer recovery support options available. You see Marigold listed there on the screen. Marigold's a solution that we're currently evaluating for application at OSF, wherein it's a text chat-based app where a peer recovery support specialist provides synchronous and asynchronous text messaging support to folks who are in recovery for substance use disorders. Reset is a little bit different. Reset is the first prescription digital therapeutic that has received authorization from the FDA for use as a prescription therapeutic, which means that providers will prescribe this tool for their patients, and then it can be covered by insurance. Reset is really cool because Reset offers some gamification. So if individuals who are using the platform, for example, maintain sobriety for 30 days, they get to spin a wheel for a reward, and those rewards may be a Starbucks gift card or an Amazon gift card or things like that. Now, while I think that's pretty cool, there are potentially some ethical concerns there with regard to essentially paying patients to use a platform. So that's something that really needs to be considered as they move forward. Digital and virtual solutions really seem to be an intuitive fit for younger people, given the sort of ubiquity of their use of technology. You know, adolescents and teenagers are really stuck to their phones. I just got my daughter a Nintendo Switch, which for some reason I think is very different than the Super Nintendo I played when I was a kid. But this has become even more prevalent during COVID. Kids are attending school virtually and being virtually forced to virtually connect with their friends and families. This being said, there are indeed complications for providing digital care to minors. Are these apps developmentally appropriate? So do they meet both the need for getting to that sort of intellectual understanding level? Are they at an age appropriate level for the kids they're trying to serve? And what does consent look like? You know, how do you get a parental consent to have a teenager or an adolescent or a kiddo use an app or a tech solution to address some of their mental health kind of considerations? Here's some examples for kids and adolescents, some tools that are being used now. Manatee is a very new one. I was just exposed to this maybe a couple of weeks ago. The idea with Manatee is that it creates a connection between a therapist, a parent, and a child. So the child uses an app to work on discrete skills to help them manage behavior problems or emotion regulation, etc. The parent is able to log activities that they've done with the kid, also journal their sort of perception of what they think the kid has been going through and experiencing as they move along. And the therapist then has access to the kid's utilization of those tools, the parents' responses and feedback and input, and then can integrate that into the treatment they provide virtually over a synchronous video connection. I think moving forward, this is the kind of thing we're going to see a lot of, primarily because in this space right now, this virtual and digital mental health, there are a lot of companies who are providing that sort of asynchronous access to digital material. And there are a lot of companies who are providing the direct virtual synchronous back and forth therapeutic interventions, but there aren't very many who are doing both. And I think that's the next step as we move forward, what we're going to see. I included Stop, Breathe, and Think here. I'm a big fan of this particular app. We are not using it at OSF Healthcare. It wasn't the right fit for us at the time. One of the reasons I'm really fond of this app is because it's validated down to younger kids being able to use it effectively. That's one of the challenges with using digital interventions for kids, is getting it to that developmental appropriateness, getting it down to that level of understanding for those younger kiddos. And this platform does a really good job of making the content cute and appealing to kids of a younger age group. It also shows some clinical efficacy for helping kids sort of with those basic emotion regulation skills. That's really the focus of a lot of younger therapeutic intervention. So I want to move in a little bit and explain our experience at OSF Healthcare when we moved into the space of providing digital and virtual behavioral health. About 5 years ago, we launched both digital and virtual behavioral health. Digital with SilverCloud, which is an asynchronous digital behavioral health platform, and with Regroup Therapy, who is a psychiatric provider, a telepsych provider from Chicago. So moving into our experience with SilverCloud. For those of you who aren't familiar with SilverCloud, it's a secure online space for managing depression, anxiety, and stress. There are many additional modules available in the near future. At OSF, SilverCloud was initially deployed as a part of our behavioral health navigation program. But what we've done was we realized that didn't work, because what we did was we started it out as an assigned model. So a behavioral health provider, a primary care provider, a behavioral health specialist, et cetera, would have to assign a user they felt was appropriate for using digital mental health to the platform. The reason that didn't work was because it was very difficult for us to socialize the availability of this platform to our 1,200 providers. It became a full-time job in and of itself, going out to these provider offices and having conversations with them about SilverCloud and how to use it and what patients it would be appropriate for. So we did something kind of radical. I went into my boss's office one day and I said, hey, you know what? Why don't we give this away for free to anybody who wants it? She looked at me kind of funny and she said, all right, go ahead. So we dug deep and figured out how to do that. We became the first health system in the United States to utilize self-enrollment to the platform as part of a strategy to increase access to mental health resources within our communities. So what we did was we made it possible for anyone who lives within an OSF area of service, so anywhere in that huge geography of 14 hospitals across Illinois and one in Michigan, 18 years of age or older, has access to an internet-enabled device, can sign up for free. They don't have to be an OSF patient. They don't need a referral, and it doesn't cost them anything. All they have to do is go to osfhealthcare.org/silvercloud, sign up for access to this digital content. Now, what we wanted to make sure we did was have a broad array of types of services available, but we also wanted to make sure that we didn't just give people access to this with no sort of support, no safety net. So what we did was we integrated a digital coach. So this is a person who provides the user with feedback, support, recommendations for additional content, and then connect individuals to a higher level of care if needed. So we launched 3 of those supported platforms, one for depression, one for anxiety, and then what we call our combo platter that addresses concerns of depression and both depression and anxiety. This stands to reason given the really significant comorbidity between depression and anxiety. We felt like that's the most likely use case, and that has borne out in the data of our over 8,000 users. The vast majority have signed up for the depression and anxiety platform. Now, we also offer an unsupported space from stress module with those lower level acuity interventions. This one's just completely anonymous and without that additional coach and supporter. So the space from stress provides things like relationship management, et cetera. Our outcome metrics here, it's kind of a busy slide, I apologize for that. shows our improvement in depression scores and our improvement in anxiety scores separated out. So for those users who are using the depression score, we measure their improvement using the PHQ-9, which is a very evidence-based and validated instrument. This data is a little old. There was only 100 and some in this, but the data has continued to show this kind of improvement. The key takeaway here from my perspective is that these improvements are very similar to what we'd expect from traditional in-person face-to-face therapy. It's almost exactly the same. Some people get better, some people stay about the same, and some people kind of get worse. What's really interesting to me when I look at this data is that those people who are more on the severe and moderate side get better at a higher rate. We haven't validated this yet with any kind of outcomes data, but we suspect that the reason for that is that those higher acuity folks that are struggling a little bit more are more engaged. You know, they have a higher level of understanding of what their need is, so they get more involved and work a little bit deeper into the platform. So this is our comorbid depression and anxiety program. So folks who are using that platform for both, as you can see, the N is much higher here, just under 1,000 when we were in this data a bit ago. Again, you can see here that the severe and moderately severe get better at a higher rate than the mild and minimal folks. And again, that I think is about engagement. What I really do think that the key takeaway is that the efficacy of this digital intervention is fairly similar and consistent with what we'd expect from traditional in-person psychotherapy. As we move forward with Silver Cloud, we're piloting a teen version. We picked a couple of high schools in our service catchment area that we know have some challenges with accessing behavioral health, particularly for teens and adolescents. So we're going to pilot that teen version. So we're working through all those considerations, like what does consent look like? How do we make sure that the content is validated with clinical efficacy, with clinical evidence? And how do we make sure that we get it into the right hands of the right kids? In addition to that teen version, we are adding additional content. As I mentioned at the onset, these digital platforms really started out focusing on sort of those meat and potatoes of cognitive behavioral therapy, you know, depression, anxiety, and stress. But we're adding more content now. Chronic pain, we know there's a significant comorbidity between mental health conditions and chronic pain. And alcohol misuse, resiliency, diabetes, and positive body image. What I haven't included here is that we're also in the middle of piloting a Spanish language version in one of our communities that has a high Spanish speaking population, because we know that that is a difficult population for us as a health system to engage with. In particular, it's difficult to engage with them from the behavioral health, the mental health side of things, because we just simply don't have very many bilingual or Spanish-speaking behavioral health providers. Okay, so moving away from Silver Cloud into our experience with telepsychiatry, what we did was, like most health systems, we have a shortage of psychiatrists. The average age of a psychiatrist in the United States right now is nearing 60. We're not seeing very many graduate from residency programs. The slots are limited. It's a longer residency. It's a lower paying specialty. So, you know, the challenge of getting a psychiatrist to attend, for a physician to go into psychiatry is very difficult. So telepsychiatry is really the only option right now for us to be able to expand the bandwidth and make sure that we have enough providers to at least make a dent in the need. So what we've done with our telepsychiatry sort of approach is develop this array of telepsych options. The first one was direct patient care via HIPAA-compliant patient-facing video conference. This was a lot bigger deal 3 years ago than it is now, just simply because so many visits have moved directly to video that this is just the norm now. You know that many people are receiving most of their healthcare through video conference with their provider. Another thing we did was we wanted to provide our primary care team, so our physicians and advanced practice providers, our nurse practitioners and physician assistants, with the ability to consult with a psychiatrist in order to improve their patients' outcomes and give those patients psychiatrically informed care directly in the primary care space. We started this by doing these live video conferences between providers. So the primary care provider would schedule a video conference with the psychiatrist from Chicago and talk about a case, just get a consult. This fell flat on its face. And the reason it fell flat on its face is because if you've ever been to a primary care provider, they're almost never on time. So what would happen is they would schedule that visit with the psychiatrist, something would happen in their schedule, and they'd end up being behind and miss the time window for the live consult. Whoops. So what we did was we kind of pivoted. We said, okay, well, that's not going to work. How do we make this easier for our providers to access this same content? So what we did was developed an asynchronous electronic consultation. This was comprised of a chart review, treatment and testing recommendations provided to the PCP directly through the medical record. So all the PCP has to do is put an order in for an electronic consult for psychiatry. Psychiatrist reviews the chart, reviews the meds, reviews any interactions, and makes recommendations for ongoing treatment and additional testing. This often results in, questions about diagnostics. Okay, does this patient really have this disorder, or did they just come into your office and say they had previously been diagnosed with it? So let's validate that and move forward with the interventions that are necessary for that patient. Like I mentioned earlier, I'm a data nerd, okay? It's important for us to collect data about both the clinical efficacy and the patient experience with this tool. So we wanted to make sure our patients were heard and understood and supported, and how much they liked or didn't like those video visits. As you can see, there's a high level of patient satisfaction, primarily because this reduced their wait time and got them access to psychiatric treatment that they would either have had to wait a long time to get, or they would have had to drive a long distance to see a provider. So moving into the EConsult outcomes, our providers overwhelmingly, our PCPs, were satisfied with the content that they received from the psychiatrist through the EConsult. And not only were they satisfied with it, they actually took action on it. So did they implement the recommendations that were made by the psychiatrist? So our providers self-report over 90% of the time they did. When I reviewed the charts, I only saw like 86 or 87%, but that's still a pretty high number of those folks who are taking action on those recommendations made by the psychiatrist. So in addition to all of those kind of things, COVID has flipped things on its head. Okay, so many estimates say that COVID has accelerated the use of virtual and digital visits over 10 years. So what would have taken us in the healthcare field 10 years to implement, we've done in less than a year because of COVID. A lot of that has been made possible because of the regulatory and reimbursement changes that have been made available during COVID. So in short, what happened was the people who pay us for the visits we provide said, yep, we're going to pay for virtual, no questions asked. Go ahead and do it. We know the people need it. So that's made things a lot easier to transition into these virtual visits. Within our behavioral health service line, we provided very, very few video visits in fiscal year 2019. Just those very few telepsychiatry visits that we were providing in one or two of our offices across the system. By rapidly and scaling those virtual visits in 2020, we've done over 12,000 video visits in the behavioral health service line in 2020. So what we know is that COVID has absolutely accelerated it. And we know that COVID will continue to accelerate and probably change the whole sort of landscape of behavioral health. Like I mentioned, COVID has served as a massive, massive disruptor in all sectors. It's changed the way we view our work. It's changed the way we dine out. It's changed the way we spend time with our families. Arguably, it's disrupted healthcare more than any other industry. It's forced us to re-examine what we believe to be the right and only ways to deliver effective healthcare. Moving forward, I think we're going to see a continued proliferation of virtual and digital care, along with any other number of innovations. Here's what I think that we're going to see in the next few years, if not sooner. Virtual reality. I think VR is on the cusp of exploding in the behavioral health field as something that can be useful from autism to ADHD to anxiety and substance use disorders. I think there's a huge number of applications where VR can be very valuable tool in providing behavioral health care. Can you imagine doing some desensitization work with someone who has a generalized anxiety disorder or possibly a specific phobia by using VR? Or can we help kiddos or young adults with autism become less challenged by those sensory integration issues that those folks have? I've already evaluated a couple of these VR solutions. I don't think they're quite ready just yet. Some of the tech is a little glitchy, but it's evolving so rapidly that we'll see these solutions in real world applications. I also think that we're going to see some machine learning and artificial intelligence. This is already pretty widely available in chatbots and the like. If you go to osfhealthcare.org right now, we have a little chatbot at the bottom of our main page that can help direct you to COVID resources or mental health resources, or find a primary care provider, whatever the case may be. I think these are going to undoubtedly play a role in moving forward, both in direct patient care and in the background for things like wearables and digital phenotyping. And I think there's direct potential opportunity here, but there's also a bit of risk. Wearables and this idea of digital phenotyping is going to be really, really prevalent in the near future. So, for example, we can gather heart rate data for someone with anxiety. We could gather location services for somebody battling substance use disorder, right? So we can know if someone who has some alcohol use disorder or trouble with alcohol, we can know that they're sitting at a bar. We can look at movement data for someone who has depression and maybe is less active than they need to be. Now, the challenge here, of course, is the ethics involved with all of that data transfer and accessibility that we touched on earlier. And the major question is, will this cause more trouble than it solves? These are all sort of these ethical and practical concerns that we have to kind of talk about moving forward into this next phase of what digital and virtual behavioral health is going to look like. We really don't know what the future holds, but we do know that, like I mentioned, COVID has really sort of flipped things on its head. So our ability to adapt and quickly adjust in a rapidly shifting world needs to be at the forefront, and digital is absolutely going to be at the center of that. So now, given that we only had about an hour, I wanted to leave a few minutes at the end for any kind of discussion or questions that you all might have, and we'll go from there.
Yeah, at this time, if you could go ahead and type your questions, if you have them, in the chat to the side or under the questions box that's there, either one will work. Thank you very much to our speaker today. Thank you so much for being here. That was an incredible presentation. That is definitely the type of stuff that gets me excited about behavioral health. And I think, especially with COVID, I've been trying to search a lot more for silver linings, and I feel very much like we've kind of been in this big experiment, and there's a lot of things going on. I will say your presentation was so specific. I was trying to write down questions as we went, and I feel like you answered about 4 sticky notes with the questions that I wrote down. But one of the things that I was going to ask about that you did give a figure for that I thought was interesting was how much have we accelerated as far as not only rolling out some of these applications or developing them or having an organization like OSF buy into them, but how much as society or community members buy into using them in a reasonable and helpful way. I mean, do you really think we are, I think you said 10 years or something like that? Is that
Yeah. I mean, one of the challenges in healthcare is that it's difficult to make change because it's a large moving ship, and it's an inertia-bound system. So, without some kind of catalyst for change to disrupt the status quo, it's hard to make that change quickly. And COVID certainly served that for us.
Absolutely. So on some of these apps, and this is something that you touched on too, that I was thinking about, how is there a substantial learning curve with these, especially when we're talking about the elderly? You touched on one of those trends that I think a lot of us are familiar with, and reaching out for help with a mental health crisis or something like that, and having more youth be engaged in that. And you said that was kind of the trend that even took it to the next level during COVID. Do we need to be concerned about those things if we're dealing with clients that are elderly or aren't very technologically inclined?
That's always a question with a lot of these kind of tools. And I thought so, especially when we launched Silver Cloud. I thought, okay, this is going to be, a challenge with some older folks who, like, I know my dad's 70 years old and has a flip phone, right? Like, there's no way he's going to use this stuff.
Right.
But I was surprised. Like, I was taken aback by how many older folks actually engaged and did really well, and I think what we realized was that we were probably underselling the capabilities of a lot of older folks, and saying, these people are definitely using tech. They're FaceTiming their grandkids, they're on Facebook, swapping stories back and forth and pictures, and the usability, a lot of the tools is very similar to what they'd experience with a social media application. So I think there's a higher comfort level there than I certainly thought there was when we started it.
Yeah, I've definitely learned my lesson about judging too early in those situations. I think a lot of people have more capabilities than sometimes we assume.
Yeah.
You mentioned stuff about VR, and I think that that's really cool too. I mean, honestly, I don't think we're quite there yet, but I'm not someone that's had a lot of use of VR even in a leisure setting. And you talked a little bit about some of the things it might be used for, but do you see any sort of applications that are in the works out there that you think are realistic and we could see in the near future?
Yeah, I was part of this innovation challenge it's called the MASS Challenge. So it's the University of Massachusetts Challenge for tech delivered startups. And I can't remember the names of the companies off the top of my head, but we saw 3 or 4 that were VR delivered. And some of them did a broad array of therapies. So not just like psychotherapy or therapy for, folks who have a behavioral health condition, but they were doing things like PT, so that the patient could really experience that physical therapy experience that they would in person, just in a virtual way. So I think you hit the nail on the head. I think it's coming. I think the tech is early, but it's going to get there.
Yeah, that's some exciting stuff. So I'm happy that we've seen a little bit of an acceleration here, so we can see some of these things maybe a little bit earlier than we would have without COVID.
You bet.
So I'm not currently seeing any questions come in. I'll say I saw a market drop in our attendees right here as the weather started to get pretty terrible here in central Illinois. So if you are in central Illinois, and if you are in central Illinois still and you have to drive home, please be safe. If you're watching this on YouTube and you have questions for either myself or our speaker today, please reach out to me or McLean County Behavioral Health, and we will get an answer to your questions. I want to thank our speaker one more time for being with us today. Again, an excellent presentation. And for everyone viewing today, we hope to see you at our future presentations as well. Thank you.
Take care. Thanks. Bye-bye.